Mansi, can I check my slides? Mansi?
Yes, sir.
Can I check my slides?
Yes, sir.
All right, visible?
So just screen is visible, just put it on flat show.
All right, visible?
Yeah, so just moving.
Fine. So I'll stop sharing.
I think we got quite a few people on Facebook as well as YouTube, and we got about 27 people right here on the Zoom, so people will join. It's 5 o'clock, and ladies and gentlemen, we are here live with the Freedom Series. Freedom Series is started on 26th January of this year, named because of started on 26th January, a joint collaboration between Indian Academy of Neurology and Association of Physicians of India. We have President of API, Dr. Shyam Sundar, with me, and I here welcome you all. We are running into a wonderful session every month. This is once in a month on the Sunday evening, 5 o'clock to 7 o'clock, and the coordinator for this session along with API is Dr. P.K. Maheshwari, which is now joined by Dr. Rajendra Bansal from Ludhiana. Earlier was supported by Professor Gagandeep Singh. Today we have a very, very eminent speaker, my colleagues from Indian Academy of Neurology, and you will hear them. Dr. Satish Khadilkar, the past president of Indian Academy of Neurology, is here, who himself has started many series of education for physicians during his tenure. We also have Thomas Matthews from Bangalore, Dr. Sina from Bangalore, Niemans, and Professor Gulati, the pediatric neurologist from AIMS. So this session is, I think, first time a session on myopathies has been discussed on the IEN platform, and I really feel very elated that this series is going on well. And I welcome Dr. Shyam Sundar and would request him to say a few words and his thoughts about this series.
Thank you, Dr. Surya. It's really, as you have already said, that this is the 6th lecture in this Freedom Series. And I am sure members of API and IAN both benefit with this mutual cooperation. And in past also, all the lectures have been very much praised and very much useful to the members as I got the feedback. And I'm sure today's session will also be equally beneficial to both the members of both the associations. The myopathies, we often come across the myopathies and Myasthenia Gravis slightly uncommon, but even then, I mean, in our practice, not much is discussed about these conditions. So it is very nice that you have chosen this topic for the Freedom Series lecture. And I wish this session a great success. Thank you.
Thank you, Dr. Shyam Sundar. And I hand over to the coordinator, Dr. Maheshwari ji and Dr. Bansal from here onward to take it further.
Thank you, sir. May I invite Dr. Satish Khadilkar. Topic is inflammatory myopathy. He is very well known. He is Dean Bombay Hospital, Mumbai. He is also past president of the Indian Academy of Neurology. He holds so many positions at the present, and his publications are enormous. And main He was editor-in-chief from 2012 to 2017. He has edited 6 books, 43 book chapters, and over 150 publications in national and international, and everybody knows about his name. Now over to Dr. Khadilkar.
Thank you. Thank you very much. Firstly, compliments to all the organizers. This is such a fantastic thing that you started. I think physician and neurology contact is so important, as we realized over the years. So thank you very much for starting this session. And also thanks for choosing myopathies, because it's a kind of an orphan topic and not selected every now and then. So it's a pleasure for me to participate. And I think the first talk I'm doing is an overview of what physicians should know about the myopathies. And then, as you will see, there will be 3 talks which will go in more details of some of the important myopathy topics. So let me start with the first one. Right, my slides are visible?
Yeah.
Right.
Yes, sir.
So myopathies is a huge topic, and I have sort of titled it, What Physicians Should Know. So I'll take you through the important ones. Oops, the slides are not moving. Yeah. Now see, if you open up any textbook of neurology, the classification of myopathies will look something like this. This is only one of the 7 pages that you will hear. But don't get into this. This is for the neurologist. For the practicing physician, myopathies are very simple. In fact, very, very simple. This is what you need to know. You basically divide them into inherited problems and acquired problems. So the key question is this a genetic disease? And then, as you can see on the left side of the panel, the inherited myopathies can be of different types, and I've listed a few common ones here. Dystrophies, congenital myopathies, myotonias, mitochondrial myopathies, periodic paralysis, and storage diseases of various types. And on the acquired side, it's endocrine, inflammatory, toxic, drug-induced, deficiency, and metabolic. Now, this is the basic format of how a physician should look at myopathies. Question number 1, is it a gene-related disease or not? If it's gene-related, then you probably need to take help of a neurologist. These are some of the points that I always mention, so I have put these down. Then when trying to understand whether it's a genetic disease or not, take into account the size of the family, don't neglect the mother's side of the family, and please remember that the presentations of myopathies can be really very pleomorphic. And a good example is myotonic dystrophy, that somebody may have cataracts, someone else may have diabetes, someone else may have alopecia, someone may have infertility, and someone may have myopathy. And patients will not know that all these are connected. So that's your skill to try and understand how these are correlated. So coming back, the first question, is this a genetic myopathy? Now, once you know that it's a genetic myopathy, what are the questions in front of you as a physician? I don't think you're going to be too interested in what is the type of myopathy and what is the subclass and what is the genere and which is the gene and which is the mutation and all that. That's the academic part of myopathy. But what do you need to know? Can I establish the transmission? Can I detect the culprit gene in India by doing some test? What counseling can I offer to my patient? And can I prevent this disease from going in the family? So, as I told you, try and find out whether it's a genetic disease or an acquired disease. God, I seem to have lost the connection.
Has Dr. Khadilkar logged out?
Yes, sir.
He must be trying to rejoin. Share me the YouTube link also, please, on my cell.
Yes, sir. I'm just.
Just ask him if he's relogging.
Yes, sir.
Once you can just find out if he's, there he is. Yeah, he's logged in.
I seem to have lost the connection for a while. Am I okay to go on now?
Yes, please.
Yeah. Right. So I'm sorry, I somehow lost the connection. So these are the 4 questions that the physician needs to answer when it's a genetic myopathy. Now, genetic myopathies is a huge group, and please remember only these. Myotonias, because you can treat them with medicines. Periodic paralysis, because again, you can treat them with medicines. Now, here is a slide showing myotonic dystrophy, the Herculean appearance of myotonia congenita, a patient with paramyotonia, and another patient with Anderson-Tawil syndrome. So amongst the genetic myopathies, you remember a few of them. But acquired myopathies are the ones that are important to physicians. And which are they? Endocrine, thyroid, adrenal, pituitary. Inflammatory, polymyositis, dermatomyositis, inclusion body myositis. Drug-induced. There's so many drugs and the list is growing, but particularly statins. Then deficiencies of calcium and vitamin D. Toxic diseases like rhabdomyolysis of various nature, and the storage diseases, glycogen, lipid, and sometimes systemic diseases. So these are important for the physician. Now, endocrine myopathies present with chronic progressive weakness, and they are limb girdle syndromes, where often the hip girdle is affected more than the shoulder, which is in fact the case for most myopathies. And here is an important word which we stress upon in neurology teachings, that endocrine, metabolic, toxic diseases do not choose some muscles and leave some muscles. They affect everything around the girdle, so no selectivity. We can discuss this point in the Q&A if there is time. And often they do not have dysphagia. CK elevation can be mild, except thyroid disease, where it can be in thousands and look like a dystrophy. And the electrophysiology can show minimal changes. So thyroid disorders, in particular amongst the endocrine, are common in clinical practice. And as you know, as physicians, thyroid chooses its end organ for whatever are the reasons that you will probably know better than me. So sometimes muscle is the only end organ chosen, and people can only come out with a myopathy, and you need to find out that that's due to thyroid. One other confounding factors in thyroid myopathy is that the muscles become large, so they can really look like dystrophies. I've had one such instance where a young child was brought to me with what was thought to be Duchenne and turned out to be a thyroid myopathy. And after treatment, the calves became smaller and everything became all right. So subsequently, that patient kept on saying that this doctor can cure Duchenne and kept on sending patients to me who were actually Duchenne, and it couldn't be helped that much. Now, this I have taken from Dr. Nalini's paper on muscle hypertrophy in thyroid. And it can be larger than that. I've had a policeman who said that his trousers he had to get stitched because the regular trousers wouldn't fit his calves. And here is one of our patients, which me and Dr. Girish Soni were seeing, where there is only a masseter hypertrophy. So thyroid and hypertrophy can make it look like a dystrophy that you have to remember. Now the two telltale signs for physicians: the slow relaxing ankle, and the myoedema. Boop. Look at the myoedema. Right. After the endocrine, we touch upon inflammatory myopathies, which conventionally are divided as polymyositis, dermatomyositis, IBM, myositis with malignancy, and myositis with collagenoses. Now, these are sporadic. These are fast. Subacute. They are proximal, and they produce dysphagia. So if you have a patient with myopathy where swallowing starts getting affected, your thoughts should start going to an inflammatory myopathy. Reverse is not true. And skin rashes. Here I have put down 3 important clinical features of polymyositis, dermatomyositis syndrome. This is the heliotrope rash, the lilac colored rash that you see around the eyes. Here, this picture depicts the neck drop. If you see a myopathic syndrome with a neck drop, inflammatory myopathy is a strong possibility. For physicians, there are 3 differential diagnoses for neck drop: inflammatory myopathy, motor neuron disease, and myasthenia gravis. For neurologists, there are about 20. And the last slide is calcinosis, where some patients develop this subcutaneous calcium problem, and which becomes so bad that they really can't be helped too much. One point I want to make here, that there is a feeling amongst physicians that inflammatory myopathies are painful. That is not so. Pain is not a common feature. It's the weakness. In fact, if you see something with a pain, then other diagnoses should come up to your mind more. And you see very high CK. Electrophysiology shows jitteriness because it's an inflammatory disease. And biopsy shows inflammatory cells invading the normal muscle fibers. And nowadays we can do an MRI also, which shows inflammation and edema. And here you see an MR where the trapezius muscle is showing edema, and this was a patient of cervicobrachial polymyositis. And this is a biopsy from another patient where there are interstitial exudates. And you can see here, this is the most important thing. The inflammatory cells are gathering around a fiber that is normal. So the cells are bad, the fibers are good, which is reverse of dystrophy, where fibers are bad and cells are good. So you treat them with corticosteroids, and you often support them with other medicines like azathioprine, methotrexate. And for rescue, you use IVIG and plasmapheresis. The third group is the toxic myopathies, where there are necrotizing myopathy, where the muscle just necros, and you have statins, tacrolimus, cyclosporine, and some other drugs as well. And then you have 2 other types of toxic myopathies, just for you to remember the groups: antimicrotubular and hypokalemic. Now, we'll touch upon a little bit of statin-induced myopathy. It is very common. Myalgias are about 10% of people who take statins. Inflammatory myopathy is much less common, 0.1 to 0.5%. And it generally links with the duration of the statin therapy. And these are the factors that increase the risk of statin-induced myopathy. There's a whole lot of drug-related interaction. So one has to be careful what you are combining the statin with. And a general guidelines for physicians: if the patient is having only myalgias, but the CPK is not raised, you continue the statin. If there are myalgias and CK is raised, discontinue the statin. If only CK is raised beyond 10 times the normal, discontinue the statin. If your patient has had a rhabdomyolysis at any time, there is no question of giving him statins again, because challenge again can be disastrous. And if the patient requires statin for whatever are his reasons, but muscle toxicity other than rhabdomyolysis, then you can think very carefully after the symptoms have resolved and CK has returned to baseline. You can try with other pravastatin or fluvastatin, but everything has to be under careful monitoring. Just to make you aware that there is a necrotizing myopathy with statins, and there is another condition which progresses to inflammatory myopathy. Now, steroid myopathy, very common in clinical practice. So usually affects the lower limbs. It hardly ever goes to the upper limbs. CK is normal. So a patient on steroid develops lower limb weakness, CK remains normal. That's the diagnosis that you look at. And you need, you may do a biopsy which shows a type 2 fiber atrophy and on the ATPase staining. Please don't forget the vitamin D deficiency myopathy because it is still seen from time to time in India. And I worked at the Grant Medical College for many years where burqa-clad multiparous women were still coming to the hospital. And from time to time, you would see a painful hyperreflexic lower limb weakness, which with a normal CK and comparatively good electrophysiology. The point of picking them up is they respond very well to therapy. We'll touch upon rhabdomyolysis. It's a very, very severe condition and can be life-threatening. And a lot of things can do it. Drugs, substance abuse, neuroleptic malignant syndrome, snake venoms, tetanus, and mushrooms. Now, mushrooms I have personally never seen. There's extreme CK elevation, myoglobinuria, and renal dysfunction. These test the physician and the intensivist in the treatment because electrolytes change unpredictably, the water balance changes unpredictably, and you really need to be on top of the game. Now, very briefly, metabolic myopathy, glycogen, lipid, and mitochondria. These are chronic myopathies as much as exercise intolerance. Most of the physicians have it in mind that if you're dealing with a metabolic myopathy, there must be exercise intolerance. But a good 50% are chronic progressive myopathy. Second, pleomorphic CNS and PNS involvement. Please don't forget the Pompe disease because it can spring up from various quarters. Clinical presentations are very protean and it's now a manageable disease. You need a good setup with a good biopsy. Panel showing lipid storage myopathy will oil red O stain. So unless your lab is well equipped and unless you're confident with what they can do, there's no point in pursuing in that diagnosis in your setup if you have worries about it. Critical illness myopathy is becoming more and more common, and it comes up during the period of that acute illness. The risk factors are steroid use, neuromuscular blocking agent, and severe disease, particularly where ventilator is used. And there are various diagnostic criteria available. Therapy as yet is supported. Physicians face this from time to time, myopathies in the ICU. So you divide them into three. Previously existent disease, which has exacerbated, where different types of muscular dystrophies, inflammatory myopathies, periodic paralysis comes into picture. Undiagnosed or a new onset, where first time the patient comes in the ICU with a myopathy, it's often a rhabdomyolysis or a toxic myopathy. And ICU-related myopathy, which develops in a patient who is admitted due to other reasons. So friends, we have gone through just getting acquainted with myopathies as a big topic. We divided it into inherited and acquired, and we said that inherited, you need to know what you can do for the patient and then pass them on to a neurologist, if I may say so. Acquired are the ones that you are very interested in and you should know more about them. Acquired myopathies are very important for you. Metabolic, endocrine, toxic, deficiency, and inflammatory disorders form the major bulk of this disease. And I think in endocrine, it is thyroid. In toxic, it is the statin. In deficiency, it is the D3 and the inflammatory myopathies. As physicians, of course, you do a good general examination before you do the neurological, and characteristic telltale features are present in a proportion of patients in each of these categories, which if you pick up, your differential becomes narrow. And a systematic approach is very important in the diagnosis and treatment of this large group of disorders. Ladies and gentlemen, thank you very much.
Thank you, sir. Very well described in brief, and later part will invite the questions. Now, may I invite Dr. Seema Bengalil from NIMHANS, Bangalore.
Is my screen visible?
Yes, ma'am.
Yeah. So, good evening all. So today, after now Professor Satish Kadalkar sir's introduction, I am going to start the talk on inflammatory myopathies. The slide is not moving. 1 second. Just 1 second. I think somehow the slide is not moving. Yeah, sorry for that. So the inflammatory myopathies are a heterogeneous group of disorders which is characterized by immune-mediated destruction and mainly centered around the muscle tissue. But there can be multiple other systems which can be involved. There can be involvement of the skin, heart, lung, joints, etc. And sometimes there can be overlap with other autoimmune rheumatological conditions. So there are distinct antibodies, characteristic clinical features, and histopathological findings. So the classification of the inflammatory myopathies include dermatomyositis, which can be of adult or juvenile onset, immune-mediated necrotizing myopathy, antisynthetase syndrome, overlap myositis, and inclusion body myositis. And as we mentioned, there can be antibodies which can be myositis specific or myositis associated. So the MSA or the myositis specific are the ones which are characteristically found or specific only for the inflammatory myopathies, whereas the MAA or the myositis associated ones are found in other autoimmune conditions also. And there can be a percentage of 20 to 30% which can be seronegative. So there were various diagnostic criteria which were proposed for the classification of these inflammatory myopathies and diagnosis. The latest being in 2017, EULAR-ACR criteria. So we won't go into details of this. This is basically they have studied various variables which can predict, and various scores are given for each of these variables, say the age of onset, muscle weakness, skin manifestations, and depending upon the scoring. If the score is more than 8.7, there is a probability that it is 90% inflammatory myopathy. So here the characteristic features which are important for the diagnosis are symmetrical weakness, especially progressive proximal weakness of upper limbs or lower limbs. So you'll have patients who might tell difficulty in getting up from the floor, difficulty in climbing stairs, or they may have difficulty in lifting weights, combing hair, etc. The neck muscles are weak, neck flexors especially weaker than the neck extensors, and the proximal weakness is more than the distal muscles. And there can be various skin manifestations, which I will show you in detail later, and associated with elevated creatine kinase and other muscle enzymes. And if muscle biopsy is done, the characteristic features are present. So coming to the antibodies, so the myositis specific antibodies, the first 8 antibodies, that is anti-Jo, anti-Ha, So, EJ, PL7, OJ, KS, PL12, these are antibodies which are directed against the aminoacyl tRNA synthetases, and these are found in antisynthetase syndrome. This anti-Jo1 is one of the most common antibodies which you will find in the inflammatory myopathies, and the antisynthetase syndrome is characterized by myositis along with arthritis, mechanics hands, and also interstitial lung disease and fever. The next 5 antibodies which we see here, Me2, TIF1 gamma, MDA5, SFE, and NXP2, these are characteristic of dermatomyositis, and I'll be telling about the details of each one later. And SRP and anti-HMG-CR, these are for the immune-mediated necrotizing myopathies. The myositis associated antibodies include PMSCL, CoO, Rho52, etc., which are associated with other connective tissue disorders or autoimmune conditions like rheumatoid arthritis, SLE, scleroderma, Sjogren's, etc., and cytosolic 5-nucleotidase, which is found in inclusion body myositis. So as we can see here, these form a heterogeneous group as well as there is considerable overlap. So as I mentioned, the 8 antibodies of the antisynthetase syndrome characterized by myositis with mechanics hand, Raynaud's phenomena, arthritis, interstitial lung disease, etc. And this form the connective tissue disease overlap with the myositis associated antibodies. And below is the dermatomyositis group, the SAE and Me2 having characteristic skin manifestations. MDFI along with the antisynthetase syndrome can have lung disease. And we have NXP2, which is more common in juvenile dermatomyositis with calcinosis, and Tiffin gamma and NXP2, which can be associated with malignancy, especially in the adult. And on the other side is the necrotizing myopathy, HMGCR, SR more severe myopathy and dysphagia, whereas HMGCR more of, and these persist for around 6 months or long. And on the other side is dermatomyositis, sign dermatitis, without the skin rash, only muscle involvement. So dermatomyositis, as I mentioned, can affect children or adults. Females are more commonly affected. There is a peak incidence around 50 years, but there is also a smaller peak in childhood, and there can be various organ systems which are involved. So this can occur as a paraneoplastic phenomena. It can even precede the onset of the malignancy, or it can occur along with that. And the more common malignancies associated are adenocarcinoma of the lung, breast, stomach, pancreas, colon, and also the pelvis, testes, prostate, etc. So let us see, as I mentioned before, these are the main 5 antibodies which are found in the dermatomyositis. So this Me2, classical dermatomyositis, skin, muscle involvement, good response to treatment, high CK is seen, but there can be recurrences and rare associations with interstitial lung disease. Tiffin gamma and NXP2 found both in juvenile and adult dermatomyositis. Tiffin gamma, more of mild myositis, more of skin rash, severe dysphagia. Both of these can cause malignancies in adult. NXP2, more of calcinosis and subcutaneous edema. MDA5, myopathic dermatomyositis, so more of skin manifestations. And important to remember that there can be rapidly progressive interstitial lung disease. Anti-SAE, it is more of like a classical dermatomyositis. Cutaneous manifestations may precede. There can be severe dysphagia also. So just we can take a look at this picture. So Me2, I'll show you the pictures later. Rash, periorbital edemas, Scholl sign, V sign, all the typical cutaneous manifestations and myositis. Whereas in case of NXP2, we also have calcinosis, edema. There is an increased risk of malignancy and dysphagia. Tiffin gamma, again dysphagia, increased risk of malignancy, severe rashes with even blistering, necrosis, pruritus. MDFI, they can have skin ulcers, rapidly progressive interstitial lung disease. So if you see a patient with a short duration history of proximal muscle weakness with or without mild myalgias, and you find the CK elevated, so the next step is you order for a myositis profile. So this is the myositis profile which is done in ENHANCE. So it is having most of the antibodies which I listed now, except for maybe HMGCR. So this is one of the unpublished data from ENHANCE. So in our experience of some 98 cases, we found overlap syndrome to be the most common, especially with Rho52. We had 28 cases of Me2B and few cases of SRP and NXP2. So there were a few cases of juvenile onset also. And you can find almost the age of onset evaluation are similar, and there is a delay in the diagnosis, especially some patients presented even 7 or 8 years after the onset of the symptoms, while in some like SRP, probably because of the rapid evolution, they present earlier. So the muscle weakness was the most predominant manifestation, but they also had skin changes, joint pains, facial weakness, contracture, breathlessness. So all these can be present. So now I'll show you the skin changes. So what you are seeing here in this first picture here, this is Gottron's papules. So what are Gottron's papules?
Since they came all the way.
They are basically violaceous papules which are present in the extensor aspect of the interphalangeal and the metacarpophalangeal joints. Whereas the Gottran sign,
Should have
what we
waited
find in the
until
second
the
picture,
answer came.
they are actually macules, which can be seen again in the extensor aspect of the elbow, knee. And this can heal with some dyspigmentation and scarring. So this is the heliotrope rash, which you would have heard about. This is violaceous erythema present in the upper eyelid, sometimes can involve the lower eyelid and the periorbital area. And this is the V sign, which is the violaceous erythema, which we can see in the anterior aspect of the neck and trunk, and the shoal sign involving the posterior part and the shoulder muscles. There can be nail fall changes in the form of dystrophic and rat cuticles called Samit sign. There can be periangual telangiectasias and cuticular hypertrophies. So we can see a nail fold capillary scopy. There can be poikiloderma with hypopigmentation, telangiectasias, and atrophy. Another characteristic feature is the Holster sign, which is very specific for dermatomyositis, wherein we can find this violaceous erythema involving the upper part of the hip and the lateral thighs extending below the greater trochanter. So calcinosis, again more common in juvenile dermatomyositis. Sometimes this can even ulcerate, and these are more common in areas around trauma or inflammation. There can be cutaneous ulcers also, especially in the sun-exposed areas, and especially MDFI has got more association with skin ulcerations and occurs in areas with prior skin inflammation. There can be cutaneous small vessel vasculitis, which is more common in juvenile dermatomyositis. So there can be palpable purpuras, livedo reticularis, etc. Mechanics hand, I'll show you the picture. So there can be thickening and scaling of the skin in the fingers, which is more common, especially in antisynthetase syndrome, but sometimes can be even found in MDFI and follicular hyperkeratosis, and these are the lesser known skin manifestation. Another sign described is the inverse Gottrans. So whereas the Gottrans was found in the extensor aspects, here we can find in the palmar aspect the Gottrans papules, and this is known as the inverse Gottrans. There can be even digital pulp ulcerations. Another sign is the sleeve sign. Just like in the area of the sleeves, we are finding it in the lateral aspect of the upper arms. So what is the association with malignancies? So in our experience, though in the Western literature, they tell there is a common association with of malignancy with many of the antibodies. In our experience, we had only 2 or 3 cases who had malignancies. We do PET-MR for them, but it is important to remember and screen for them, especially in the first 3 years following the diagnosis. And the risk of malignancy increases with older age and males. So we have to remember it is more commonly solid organ malignancies, breast, ovary, uterus, cervix, etc. in women, colon or rectum, lung, testicular, prostate. In Asian population, we should also remember that nasopharyngeal carcinoma can also be there. In juvenile dermatomyositis, the malignancy is not that strongly associated, and hence extensive testing may not be that warranted. So this shows the malignancy associations of these antibodies. So TIF1 gamma, more common associations with gynecological lung cancer, in fact, with almost all the malignancies except hematological ones. NXP2, nasopharyngeal, GIT, breast, and the seronegative group has more associations with hematological malignancies. So I'll now show you some of our cases. So this is a lady, 43-year-old lady with 2-year history of muscle weakness, proximal muscle weakness. You can also see the severe hyperpigmentation involving her face, forehead, face, and also you can see involving the upper part of the neck and also the back. And she also has got contractures as well as proximal muscle weakness and bifacial weakness. She is not able to bury the eyelashes fully. And this is another 32-year-old man. Again, you can see the severe proximal upper limb weakness. He is not able to lift the arms well. You can also see the wasting of the shoulder girdle muscles. He's having wasting of the forehead, face, and also the upper neck. So both these patients responded well to treatment. They were made to be positive and didn't have any association with malignancy. Another important thing to remember will be the head drop. There is severe neck extensor weakness in this patient, and so he is having a head drop, as well as you can find that he also has got some amount of hyperpigmentation in his face and also the upper arm, and also he is having a head drop. So in this picture, we can see a lady who is having some puffiness of the face, and also he is having bifacial weakness. Gottrans papules can also be seen. Here is a lady who is having hyperpigmentation. So these are varying degrees of hyperpigmentation, acanthosis nigricans, bifacial weakness, which can be seen. And none of these patients had malignancy. This is a lady who is pre-treatment and post-treatment we can see. So here we can see the severe bifacial weakness as well as hyperpigmentation. She has Gottron's papules as well as the inverse Gottron's, and she has improved post-treatment. And this is the calcinosis cutis which can be seen, and the X-ray showing the severe degrees of calcinosis. And also, as I mentioned, juvenile dermatomyositis. Here we can see subtle erythematous rashes, which is involving the periorbital area, face. She is also made to be positive, Gottron's papules, Gottron's signs in the extensor aspect. NXP2, again, more common with malignancies in the adults, and also calcinosis and peripheral edema. So here is a child who presented with a slowly progressive muscle weakness and contractures. Here again, you can find this Gottron's papules and the subtle heliotrope rash. And in juvenile dermatomyositis, sometimes the skin changes can be more extensive. There can be capillaries on the eyelids with telangiectasias, infarcts in the lateral aspect of the eyelid. These are Gottron's papules, nail fold capillary dropouts, calcinosis, acanthosis nigricans, etc. So this patient, there was some thickening of the skin in the lumbar area. And in this man also, you can find severe hyperpigmentation, thickening of the skin. The CT is showing the subcutaneous calcifications in this patient. So about immune-mediated necrotizing myopathy, while we see the myriad of skin manifestations in dermatomyositis, in necrotizing myopathy, it is more of just symmetrical proximal muscle weakness, high levels of CK, muscle biopsy showing necrosis with minimal inflammatory infiltrate, rarely other systemic manifestations. 3 groups, HMGCR, SRP positive or seronegative. SRP, as I mentioned before, more severe muscle disease, dysphagia, while HMGCR, variable muscle involvement, can be mild or severe, not much of other systemic manifestations, may have association with statin. So here is an SRP positive patient. You can see that he has bifacial weakness as well as severe weakness of the shoulder girdle muscle. So they can mimic like a facioscapulohumeral muscular dystrophy. So if you find a patient with a shorter duration of the symptoms with something mimicking like an FSHD with facial and shoulder girdle muscle weakness, you have to think of even SRP. So here he has his post-treatment, he has improved well. So though, as I mentioned, this thickening and cracking of the skin of the hands and feet, the so-called mechanic's hand and Heikel's feet, though it is more common in the antisynthetase syndrome, it can even be found in the others like MDFI, SRP, etc. The HMGCR antibody, here is a 26-year-old man without any history of statin exposure with proximal upper limb weakness. Usually doesn't have any skin changes, rarely can have some erythematous macules in the back. So here he also has got some mild hyperpigmented macules in the back. And previously this HMGCR testing was not available. Now Metropolis is sending it to France, and we got 2 patients with HMGCR positivity. And both are doing good with methylprednisolone and rituximab. So overlap myositis, as I mentioned, association with other connective tissue disorders or rheumatological conditions. So there are various extramuscular manifestations and distal weakness can be there. So here is a lady who is having joint pains, hyperpigmentation of the skin, contractures, etc. This lady, as I showed before, scleroderma with typical cutaneous manifestations and difficulty in getting up. Antisynthetase, again, we have to remember that if there is one of those amino acid tRNA synthetases like JO1, OJ, etc., which I mentioned, along with any one of the following like arthritis, interstitial lung disease, which you can see in the CT, mechanic's hands, or Raynaud's phenomena, or fever, which is not attributable to any other cause, we can diagnose antisynthetase syndrome. So here is a lady with OJ positivity, head drop, severe proximal upper limb weakness, mild hyperpigmentation of the back. So when do you suspect somebody with a symmetrical proximal limb weakness, acute, subacute, or chronic? Sometimes mild pain can be present, neck muscle involvement, extramuscular manifestation, CK elevated, you think of myositis. So what do you do next? So we do the CK, it may be elevated or can even be normal. So then we do the myositis profile. If it's positive, well, you have arrived at a diagnosis.
Has Sina logged out?
I'm sorry for that. There was some problem with the net. So generally, if the myositis profile comes positive, okay, we have come to a diagnosis. So, and also we should remember to do the cancer screening. So it will be important for you to do a breast examination, do a pelvic ultrasound, look the stool local blood, colonoscopy, CT scanning of the chest, abdomen, and pelvis. And as I mentioned, the risk is highest in the first year and up to 3 years, though rarely mild risk can persist even up to 10 years. We can do PET CT or PET MR if it is available. So muscle MRI, I'll show you some of the pictures. So this is a T1 weighted sequence which can be used to see the fatty infiltration or the atrophy of the muscles. And these are the stir sequences which we use to see the muscle edema or inflammation. So this is how normal muscles will appear. And as you see in this lower panel, there is fatty infiltration and atrophy. So it is not affecting all the muscles uniformly. As you can see here, some of these muscles in the posterior compartment are appearing good, but some are more affected. And here, there can be edema in dermatomyositis. There can be edema involving the subcutaneous tissue, the fascia, and also the muscles, which again can have different patterns, can be asymmetrical or patchy also. So in this first panel, you can again see the severe edema, which is involving the obturator muscles. Here there is subcutaneous edema, fasciitis, little asymmetrical, and also in SRP positive, we can also see here the facial and myofascial orientation of the edema. So here in this picture, you can see the fatty infiltration as well as edema, which needn't be uniform. And sometimes it's important also to remember that it can even just be focal changes which are seen. So there are various patterns described. It can just be subcutaneous edema. It can diffusely involve the muscle or only the peripheries, or it can be only the fascia. And even the signal intensity can be in a honeycomb pattern or high signal, etc. So there can be various differences in the antibodies also. It is less well studied. This is some of our data which shows Me2B, it is the vastus lateralis which is more commonly affected, more edema and fasciitis, whereas in the case of leg muscles, the SRP doesn't have much of edema, while Me2B has. So as I mentioned, in our experience, the malignancies have been less. Only 2 to 3 patients among all the PET-MR which we did in around 30 to 50 cases showed. So here this is PET-MR images. So you can find this is how a normal PET MIP image will be looking. Here you can find in the shoulder girdle, hip girdle, pelvic girdle, everywhere you can see the increased uptake. And this is the whole body coronal images. Again, you can find that there is increased uptake. So basically in this PET image, we are injecting a radioactive tracer. So here it is the fluorodeoxyglucose. So in areas with the active uptake or increased uptake, it means that there is inflammation. So this is how normally it will look. So here you can find the increased uptake and even seen in these images where you can find that it is more uptake or inflammation in the muscles. So here is a patient who also had a malignancy in her left breast. And this is one patient who post-COVID vaccination developed some myalgias and also proximal limb weakness with a high CK, and his muscle MRI showing inflammation and PET-MR showing inflammation. He had Rho52 and SRP positive. In this case, I want to show that this lady was treated for dermatomyositis nearly 6 to 7 years back in outside hospital, improved well, was off medications for nearly 2 years, then came with a relapse. Her myositis profile was negative, but the MRI showed significant changes. And this is the PET-MR. She had a malignancy in her left breast. There is an increased uptake in the left breast, and even there are metastases in the spine. So it is important to remember that. So this risk of malignancy may sometimes persist longer. And as physicians, you should also remember the extramuscular manifestations. So it can be lung, arthritis, and even cardiac. They can have myocarditis or cardiomyopathy. This is the report of a 16-year-old girl with PMSCL 7500 positive who underwent a cardiac MRI. Routine echo was normal. The cardiac MRI was suggestive of cardiomyopathy. So we don't routinely do biopsy in all the cases. If the clinical picture is suggestive, if the antibody profile is positive, or if the muscle MRI is showing inflammation, then we don't have to do biopsy in all the cases. But these are some of the characteristic biopsy features in the form of perivesicular atrophy. And like Kadilkar sir pointed out, you can find the intense inflammation of this non-necrotic muscle fibers. And these are the various special stains which are showing the MHC expression, membrane attack complex. This is the necrosis of the muscle fibers, etc. So briefly into the treatment also. The treatment is complex and we have to have individualized approach. What are the unfavorable prognostic factors? Presence of malignancy, the presence of antibodies like SRP, interstitial lung disease, cardiomyopathy, delayed treatment, IBM, etc. But sex, race, or the value of CK do not go hand in hand with this. So what is the first line of treatment? Obviously, it is glucocorticoids and then glucocorticoid sparing drugs like azathioprine, methotrexate, mycophenolate mofetil, or other drugs like rituximab, cyclophosphamide, etc. So generally, we use more of IV pulse methylpred, 1 gram for 3 to 5 days, and then followed by monthly pulses of nearly 2 grams. So the side effects are lesser compared to the oral steroids. So there are various regimens for the oral steroids also. You can start 1 mg per kg per day of prednisolone, maintain till the remission, and then slow taper. So we use the steroid sparing agents like azathioprine. So we have to monitor for myelosuppression and hepatotoxicity. It may be important to know the TP-MT enzyme activity to predict whether there is a chance of developing leukopenia. Cyclophosphamide we generally use in refractory cases. Methotrexate we have used in a couple of cases. Mycophenolate mofetil is also very useful, 2 to 3 grams per day. Another agent sometimes we use as second line agent or directly in cases with SRP positive or where the prognosis is not that favorable or wherein the muscle damage is more rapid is rituximab. So we can give doses as 1 gram every 2 weeks and then follow up with the CD19-20 counts and repeat doses as needed. So this is again the same in cases with more refractory status, ILD, severe muscle disease, etc. So you go for this mycophenolate or rituximab or cyclophosphamide. The skin manifestations, again, topical steroids, hydroxychloroquine, and other immunomodulating agents. Calcinosis, difficult. Various agents have been tried like diltiazem, sodium thiosulfate, bisphosphonates. Dysphagia, again, management with immunomodulating drugs. Sometimes may need PEG, Botox, etc. Interstitial lung disease, again, steroids followed by other second-line agents like rituximab, cyclophosphamide. So to conclude, dermatomyositis, they are rare autoimmune disorders with skin manifestations. So we have to know the antibody to decide regarding the prognosis and associations with malignancies and other extramuscular manifestations. Also important to remember that if the disease is chronic, we should see whether differentiated from dystrophies. Carefully look for skin changes, which I showed, and also look the CK. The MRI muscle may be helpful in the diagnosis. And if the myositis panel and if the MRI is not helpful, we go for muscle biopsy, screen for malignancies, and follow up carefully and treat urgently. Thank you.
Thank you, Dr. Seema, for an excellent talk on inflammatory myopathies. Now we have a next speaker. I think questions and answers will be taken at the end of the session. Next speaker is Dr. Thomas Matthews. Can I have a slide, please? He will be speaking on Myasthenia Gravis. Myasthenia is not as common as inflammatory myopathies, but I think it is very important for physicians to know when to suspect myasthenia and what is the management algorithm. And Professor Thomas Matthews is professor and head of Department of Neurology at St. John's Medical College, Bangalore. And he has numerous publications. He has been best postgraduate outgoing student in NIMHANS. And he started a cath lab service for stroke under neurology at St. John's Medical College. So it is my pleasure to invite Dr. Thomas Matthews for his talk on myasthenia gravis. Sir, please.
Thank you, sir. Thank you, Dr. Rajendra, for that wonderful introduction. I'll try to share my slides 1 minute. Hope you're able to see my slides.
Yes, sir.
So thank you. I thank IAN and API for giving this opportunity to give this talk on myasthenia gravis, and also Dr. Neuromuscular for specifically calling and giving me this task of presenting myasthenia gravis, about myasthenia gravis in this short span of time. So greetings from the Department of Neurology, St. John's Medical College, Bangalore, where I work. So I'll just cover myasthenia gravis in the following headings: a brief introduction on myasthenia, pathophysiology of myasthenia, the standard treatment, and what is new in myasthenia. I thought I will be a little concentrating on where the myasthenia treatment is heading, and little about B-cell therapy, complement inhibitors, FC receptor inhibitors, and other novel therapies, and conclusion. So in this short time, we'll give a bird's eye view of what's happening in myasthenia. And I may not be touching too much of the basics of myasthenia. So as you know, myasthenia gravis is an autoimmune disorder where antibodies are there against acetylcholine receptors in the postsynaptic neuromuscular junction. The classical clinical features are fluctuating weakness, fatigability, usually in the form of ptosis, diplopia. Patients have proximal weakness, bulbar weakness, various grades of weakness. And then based on the diagnosis, based on serology and electrophysiology, and in electrophysiology, we do the repetitive nerve stimulation test. We have the low frequency repetitive nerve stimulation test where you give the 3 Hertz stimulation and you get a classical decremental response. So, showing a decremental response at a low frequency, suggesting it's a postsynaptic neuromuscular junction disorder. In diseases like Lambert-Eaton myasthenic syndrome, we get an incremental response on a high frequency stimulation. So if you see the neuromuscular junction disorder, when we all learned physiology, it was very simple. We had acetylcholine and the acetylcholine receptor. Now it has become complicated, and we have a lot of molecules and proteins surrounding this acetylcholine receptor, like you have the MuSK, you have other agrin, then you have rapsin, you have various ryanodine receptor, potassium channel receptor, proteins like titin, cortactin. So it has become complicated. So in myasthenia classical, which is an autoimmune autoantibody mediated disease, we get anti-acetylcholine receptor antibody in around 85% of patients. We get anti-muscle specific kinase antibodies in around 6%. And in seronegative in 9%, the double negative is called the seronegative. You take the seronegative group, you get antibodies against anti-low density lipoprotein receptor related protein 4. You can have antibodies against titin, ryanodine receptor, agrin, collagen Q, potassium 1.4 channels, cortactin. So in the seronegative group, based on where you work and you have the research facilities, you may find more and more antibodies, which we were not routinely commercially available for us to test. So this is an autoimmune autoantibody mediated disease. And from where these antibodies are coming? These antibodies are coming from the B cells. So we can say that myasthenia gravis is a B cell mediated disease, but they are T cell driven. So the B cells and T cells are together. They're like husband and wife. They work together. The T cells, the B cells antigen present to T, and the T helps the B cells further to multiply, and they multiply, and the autoreactive B cells multiply and then produce antibodies, and then cause this myasthenia gravis. So if you see the acetylcholine receptor antibodies, it belongs to the subclass of Ig1 and Ig3, and it activates the complement pathway. The anti-LRP4 antibody also belongs to Ig1 subclass and activate the complement pathway, while the MuSK antibody does not activate the complement. And the MuSK myasthenia usually comes with bulbar symptoms. They might have fasciculations in the tongue, and occasionally they can also have ocular symptoms, and that give a clue that there's a chance that you mistake it for motor neuron disease and or because of the fasciculation. So in the conventional teaching of neuromuscular junction, you don't get these type of fasciculations in the tongue, and also you need to suspect the MuSK antibody. And the MuSK antibody can be hypersensitive to your pyridostigmine, and some people can worsen with pyridostigmine when you give for MuSK antibody-mediated myasthenia gravis. So the B cells are the ones which are the main culprit, though they are T cell different B cell. And if you see the B cell pathway, we start with a pro-B cell becoming a pre-B cell, then immature B cell, mature B cell, activated B cell. And the antibody secreting cells are the plasma blast, the long-lived plasma cells, and the plasma cells. And if you see a good marker of the the B cells are the CD20 molecules, and the CD20 is present on the middle chain of the B cells. That is on the pre-B cell, the immature B cell, the mature B cell, and the activated B cell. And when you give the B cell therapies, they focus on the CD20 main. And then we have the plasma cells. If you want to target the plasma cells, we have to do something with the anti-monoclonal antibodies against the anti-CD38. So in the T cell abnormalities, if you see in myasthenia, you have an upregulation of the pro-inflammatory CD4 helper T cells like the T helper 1, T helper 2, and T helper 17. And also you have functionally deficient T regulatory cells. And especially so, there's a subgroup of T helper cells in the follicles of the follicular subtypes, which are called the T follicular helper cells and the T follicular regulatory cells. So in the thymic germinal centers, we have a hyperactivity of this T follicular helper cells and a defective T follicular regulatory cells, which causes the B cells to differentiate into memory B cells and the plasma blast and the plasma cells, which secrete the antibodies against the acetylcholine receptor or various other antigens, and then cause this myasthenia gravis. And the germinal centers of the thymus provide an ideal environment for differentiation and proliferation of these autoreactive B cells. But the thymus won't explain everything of myasthenia, because even after thymectomy, the antibody levels do not disappear completely from the serum. And I have recently had a patient who underwent thymectomy 7 years back for something else and developed myasthenia now. So it's not that, it's a very, very, very direct relationship. It may be something more than that. So especially there can be persisting memory B cells and long-lived plasma cells in the secondary lymphoid organs and can replenish short-lived plasma cells that secrete antibodies. And that may be a reason for, the persistence and appearance of myasthenia even after thymectomy. And the long-lived plasma cells are not affected by drugs such as corticosteroids or cyclophosphamide or even B cell depletion. And that may be a cause for one of the factors for resistance in a group of myasthenia patients who don't respond to treatment. So, and how do you manage myasthenia? So once you suspect a patient with ptosis or diplopia, you have simple bedside tests to diagnose. You can demonstrate fatigability. You ask them to look up and see that their ptosis is worsening. You can ask them to abduct the hands or stretch the hands and see they're fatiguing, the weakness is fatiguing. You can take an ice and cover it with a gauze piece and keep on the eye for 2 minutes and see that there is an improvement with the ice pack, a more than 2 millimeter improvement. Widening of the palpebral fissure may tell that there is a neuromuscular disorder. So you can use the ice pack, and ice pack is not specific for myasthenia. It can also be used for a Lambert-Eaton myasthenic syndrome. So it helps in neuromuscular transmission, cools the neuromuscular, reduces the enzyme activity of acetylcholine esterase, and then it can help in improvement. These are simple bedside tests. And then you do acetylcholine receptor antibody, a MuSK antibody if you suspect, and do the antibody profile. And then you do the repetitive nerve stimulation test and show the decremental response. And then two important tests to be done is a CT test to rule out there is a thymic neoplasm or a thymic hyperplasia, and then do a thyroid function test, because both hypothyroidism and hyperthyroidism can be associated with myasthenia and worsen myasthenia. So once you confirm the diagnosis, you go for the treatment of the myasthenia, and you know it's an autoimmune disorder. So we select drugs which affects the immune system. The person comes with myasthenic crisis. That means he's having bulbar weakness or respiratory difficulty. And then we go for an aggressive treatment to remove the antibodies. So one of the ways to remove the antibodies is a therapeutic plasma exchange, or you can do an intravenous immunoglobulin. So these are the two main things for myasthenic crisis. And then for a pure ocular myasthenia, somebody with only ocular weakness, you may just give symptomatic treatment unless it's getting generalized. And if the pure ocular myasthenia remains for more than 2 years, the chance of generalization is less. But for other myasthenias, generalized myasthenia, you go for an immunomodulation, and we have 2 types of immune modulation. One are broad-based therapeutic agents, or we can use monoclonal antibodies, which are B-cell strategies. So we see the broad-based immune therapies we use in myasthenia. We have corticosteroids, then we have azathioprine and mycophenolate, we have methotrexate, we can use tacrolimus or cyclosporin. Corticosteroids activates or suppresses target genes and causes a multitude of changes, including suppression of antigen production and reducing circulating T cells. Azathioprine, mycophenolate, and methotrexate interferes with T and B cell proliferation by cell cycle arrest, while tacrolimus and cyclosporin inhibits the T cell activation. So they act in different ways, and at the end of the day, they causes the mechanism of action is either a T or a T and B reduction in the function of T and B, and then reduction in the production of antibodies that can manifest as a clinical improvement. But there are problems with broad-based immune therapies. They take months to act. For if you take azathioprine or mycophenolate, it takes 3 to 4 months or longer to produce clinical improvement. So we have to wait. In those periods, we have to cover up with steroids. And the steroids, we know, though effective, have the potential to precipitate myasthenic crisis at higher doses, especially within the first 2-3 weeks of initiation of therapy. And broad-based immunotherapies have side effects, and steroids, I think all of you know, that can cause a lot of side effects: hypoglycemia, hypertension, hypokalemia, acneiform eruptions, cushingoid features, cataracts, avascular necrosis, gastric ulcers, opportunistic infections like tuberculosis, especially when you combine steroids with other immunosuppressive agents. Azathioprine can cause bone marrow suppression and liver dysfunction. You may check the TPMT and then choose whether to give azathioprine or not. Mycophenolate can cause leukopenia and increased risk of infections. So what is new in myasthenia in the therapeutic armamentarium? We have the B-cell strategies. So you know the rituximab is used for many diseases, many autoimmune diseases. It is more useful or more responsive. The myasthenia is musk myasthenia, which is very much responsive to rituximab, followed by, it's also useful for acetylcholine receptor antibody mediated myasthenia. The advantages of rituximab are a faster onset of action. The B cells get depleted in almost a matter of 3 days, around 90% or 100% the B cells is depleted in no time when you give rituximab. The longer duration of action lasting between 6 months to 9 months or 12 months, less frequent infusions, and a favorable side effect profile. How does this rituximab act? It causes the depletion of the CD20 positive cells by complements mediated cytotoxicity, antibody-dependent cell-mediated cytotoxicity, and apoptosis. It can also increase the T regulatory cells, which favorably influences the myasthenia gravis immunopathophysiciology. So a recent article in JAMA on the comparison between rituximab treatment for new onset generalized myasthenia and refractory generalized myasthenia gravis from Switzerland. They had around 113 patients who were treated with rituximab from 2010 to 2018. And they had around 2003 to 2012 conventional treatment cases. And they identified subgroups of new onset and refractory cases. And when they compared, they found that clinical outcomes with rituximab appeared to be more favorable in new onset generalized myasthenia gravis. And rituximab also appeared to perform better than conventional immunosuppressant therapy. And these findings suggest a greater benefit of rituximab earlier in the disease course, and a placebo-controlled randomized trial to prove these findings are warranted. And that was their conclusion. So we had a paper which I had done early in 2016 because it was a short case series. It was difficult to get published initially. It took time. But here what we have given is we gave rituximab to early onset myasthenia gravis patients and refractory patients, as well as patients in impending myasthenic crisis. So what we found that in the patients with early onset myasthenia gravis, they had a beautiful response when you give rituximab, and the response were sustained. While patients with late myasthenia who has already had multiple drugs and refractory had not that good response to rituximab, and complications rate of infections were high in this subgroup. And the most surprising findings were the patients with impending myasthenic crisis. The impending myasthenic crisis is defined as a rapid clinical worsening of myasthenia gravis that, in the opinion of the treating physician, could lead to crisis in the short term. So we know that the patient comes with a mild bulbar weakness or a mild respiratory weakness. You know that he is not that bad to go to the ICU. And then what is the option now? So we have two options. We can go for IVIG or you can go for the plasma exchange. But you know that it's not difficult. It's not that easy in the Indian context to give IVIG and plasma exchange for all patients because of various reasons. I will just tell you. So these group of patients went to rituximab directly. And surprisingly, 4 out of 5 patients did not need IVIG or plasma exchange, and they had a significant improvement. One patient we had to give IVIG because he had a very rapid worsening. So around 4 out of 5, we can manage only with rituximab. No IVIG, no plasma, no sugars. A little bit of predostigmine, and then little dose of predostigmine, and then rituximab help in impending myasthenic crisis. So as we just mentioning, IVIG is prohibitively expensive and the effects last only a few weeks. So our expenditure is taken by the patients usually. And so to get pulse IVIG and all the stuff for the patients, and also therapeutic plasma exchange is also expensive in many centers. It is inconvenient at times and uncomfortable, cumbersome, carries risk of infections and hypertension. So rituximab direct for an impending myasthenic crisis is a very interesting option which we need to explore and to have larger studies. And this is a small group of patients, so to generalize will be difficult, but it's an interesting concept which can be employed in countries like India. We have resource limited settings. So now these are in brief about myasthenia, where we stand with respect to the standard treatment and the B-cell therapy. Now we'll just see where is the trend of things going in myasthenia, because of various reasons, because as you know that the standard treatments and all treatments have some amount of side effects and problems. So what is happening? And the group of patients don't respond fully to any treatment. So we have something of complements in myasthenia. We know that the complement cascade in myasthenia at the beginning of pathophysiology, we heard that the IG1 and IG3, especially with respect to the acetylcholine receptor antibody positive myasthenia and the LRP for myasthenia, the complement cascade is stimulated. And the binding of anti-acetylcholine receptor IG1 antibody to the acetylcholine receptor epitopes activates the complement pathways. There are various animal models of myasthenia, like experimental autoimmune myasthenia gravis in mice and rats. They've shown that there is deposition of IgG, C3, complement 3, and membrane attack complex in neuromuscular junctions. And knockout mice deficient in complement 3, 4, 5, 6 have a less chance of getting experimental autoimmune myasthenia gravis. And all these things tells that there is a deposition of complement and has some role in this damage of neuromuscular junction. So if you see the complement pathways, we have the classical complement pathway, we have the alternate complement pathway and the lecithin pathway. But all these pathways at the end have a C5 convertase which splits the C5 into C5a and C5b. And this C5b combines with the complement C6, C7, C8, C9 to form the membrane attack complex, which forms channels or the pores on the cell membrane and destroy the cell. So the terminal steps in the cascade result in formation of C5 convertase, which splits C5 into C5a and C5b, and the C5b combines with C6, C9 factors to form the membrane attack complex. And the complement cascade is one of the principal pathways that leads to destruction of the neuromuscular junction and results in reduction in acetylcholine receptors and voltage-gated sodium channels. And of all the current treatment options available, only IVIG has some effect on the complement and none others target the complement pathway. So now we have the complement inhibitors. We have eculizumab, which is already used in paroxysmal nocturnal hemoglobinuria and hemolytic uremic syndrome. So eculizumab has also been tried in many neurological diseases like neuromyelitis optica and also in myasthenia gravis. And then we have other molecules which are complement inhibitors are in phase 2 studies. We have silucoplan, then you have ravulizumab. These are all molecules which are under phase 2 studies. And there is a study of REGAIN, which is the safety called the REGAIN, which is the which evaluated the safety and efficacy of eculizumab in anti-acetylcholine receptor antibody positive refractory generalized myasthenia gravis. It was a randomized double-blind placebo-controlled multicenter study. And the main primary efficacy endpoint was change from baseline to week 26 in myasthenia gravis activities of daily living score, and measured by the worst rank ANCOVA. And the study was actually negative statistically, no significant difference between eculizumab and placebo, but they found that myasthenia gravis exacerbations was less in patients in the eculizumab group, and also the patients in the eculizumab group required less rescue therapy, and eculizumab was well tolerated. So these were the findings of this REGAIN study. And in the open label extension, where the placebo group also was put on the eculizumab, and they found that the number of people who achieved minimum symptom expression increased after eculizumab, and this was sustained from 130 weeks. So from 1.7 at baseline, the placebo, it increased to 27.8% with respect to myasthenia gravis activities of daily living, and myasthenia gravis quality of life also improved from 1.7 to 19.4%. But infections with eculizumab, we know it can cause meningococcal meningitis. You have to vaccinate before starting eculizumab. But also other infections occur in this subgroup like Pseudomonas, CMV, and Aspergillus, and even septic shock. So we have to be careful with these drugs because there can be a chance of infection. There's a new class of molecules which are called the FC receptor inhibitors. What is FC receptor inhibitor? The concept is that there is a subgroup of receptors called the neonatal FC receptor, and it has a pivotal role in maintaining IgG homeostasis. And what happens when an IgG binds to the FC receptor, it prevents that IgG going to the lysosomes. So it protects the IgG from the lysosomal degradation. So it prolongs the half-life of IgG and albumin, and that is what FC receptor does. And when you inhibit this FC receptors by an anti-FC receptor antibody, it was shown that, especially in the rat models, that it lowers the anti-acetylcholine receptor IgG levels. And there was a significant reduction of symptoms in the animal models. So the phase 2 studies have been started with this and FC receptor inhibitors. And one of the advantages of this is that it acts only on the IgG class. IgG doesn't affect IgM, IgD, and IgE. And it causes an immunoglobulin reduction without any other effect on other immune systems. And so the risk of other immune-related complications of broad spectrum therapies are not. So it can be compared to a chemical equivalent of plasma exchange. And that's what the FC receptor inhibitors. We have few FC receptors under study. We have the FGAR-TG mode, nipocalimab, rozanolixizumab, and one RVT-1401. So then there are other novel therapies, which are, one is called the anti-plasma cell strategy, as we've seen in the pathophysiology. There can be this short-lived and long-lived plasma cells, and these long-lived plasma cells can stay for years, and they secrete these antibodies. And all your B-cell strategies and broad spectrums, even cyclophosphamide, may not touch these long-lived plasma cells. So you need special anti-plasma cell strategies, which may be useful in refractory myasthenia patients. Then there are new techniques of chimeric antigen receptor T-cell therapy. You take patients on T-cells and modify them and make them capable of attacking certain antigens. And then of course, you have the hematopoietic stem cells transplant, which can also be done. These are other novel therapies which are coming up in phase 1 and phase 2 studies. In anti-plasma cell strategy, we have the anti-CD38 antibodies, and then we have daratumumab. And then for the anti-plasma cell strategy, we have the proteasome inhibition, while bortezomib, which already the hematologists are using for multiple myelomas. So they cause ineffective clearance of pro-apoptotic proteins from highly active plasma cells, leading to cell death. And there's a new molecule called the carfilzomib. The carfilzomib is a more selective for the chymotrypsin-like subunit of the proteasome. Bortezomib causes peripheral neuropathy in around 6%, while this carfilzomib causes peripheral neuropathy in only around 1%. In the CAR T-cell therapy, or the chimeric antigen receptor T-cell therapy, the patients on T-cells are taken, they're harvested, they're manipulated ex vivo, and redirected against selected antigens. And this concept is taken from cancer oncology. And these T-cells are reinfused to attack certain antigens. So we have the chimeric autoantibody receptor T-cells have been developed to target autoreactive B cells. So it can be like a B-cell strategy like rituximab. The patients on T-cells are taken and then they attack the B cells. So the currently phase 1 and phase 2 trials are underway using CD8 positive CAR T therapy directed against plasma cells that express B-cell maturation antigen. So these things are underway, and we may have better therapies in future. Hematopoietic stem cell transplant, there are retrospective case series of few patients with severe refractory myasthenia patients who they underwent hematopoietic stem cell transplant, and all patients were in complete stable remission on a median follow-up of 40 months. And at 8 months after the hematopoietic stem cell, all patients had discontinued their other immunosuppressive therapies. So in short, in conclusion, I would like to say that myasthenia gravis is an autoimmune disorder where you have antibodies that targeting acetylcholine receptor antibodies or other molecules like MuSK And then we have other seronegative subgroups where you have the LRP4 antibodies and anti-aggregated antibodies. The diagnosis of myasthenia is based on the clinical features where we have fatigability and fluctuation, and you have to do the serology and electrophysiology, especially a repetitive nerve stimulation test and an ice pack test in the bedside to diagnose myasthenia. And for crisis, we use IVIG and plasma exchange. And then for immunomodulation, we use the broad spectrum or a basal strategy. And new strategies are coming up, like the anti-FC receptors and the anti-plasma cell strategies and hematopoietic stem cell transplant are the new strategies coming. So treatment strategies myasthenia are evolving, and they're becoming more disease specific, and combination strategies may be the ideal way to go ahead. Thank you.
Thank you, sir, for nice overview of myasthenia gravis with current concepts and the modern therapy. Kindly stay to the last for the panel discussion. And may I invite Dr. Shefali Gulati. She's she's Chief of Child Neurology Division in All India Institute of Medical Sciences, New Delhi. She is Professor and Program Director in DM Pediatric Neurology Program. She has got an interest in the autism, epilepsy, neuromuscular disorders, cerebral palsy, neuromodulation. Her publications are wide, more than 368, and so many talks are there. And important positions held is a President-elect Association of Child Neurology India to 2023 to 2025, and founder member Association of Child Neurology, Chairperson Academy of Pediatric Neurology, Executive Board member Indian Epilepsy Society, co-convener Pediatric Epilepsy Subsection. May I invite Dr. Shefali Gulati.
Thank you, sir. Thank you, sir. Sorry, sir. I had a parallel. I'm in Gwalior. I'm making a talk, so that talk got delayed. So I'm sorry I joined a bit late. Thank you so much. I thank Dr. Nirmal Surya sir for giving the opportunity. Sir, full screen ho gaya, sir?
Yes.
Okay. So I'm sorry I missed the entire thing because I'm in Gwalior for another pediatric neurology CME. I'll be touching about the congenital myopathies, what is the spectrum and how do you approach and what is new in the area of congenital myopathies. Basically, whenever we are talking about any child with any muscle thing, you have to go back to the motor unit. And from the motor unit, you have to again understand and see whether it's proximal or distal involvement or weakness is there, and how we can, come and to see whether the child is having a muscle disorder in which you have a relatively preserved reflexes and facial weakness. So basically, maybe a central component which coexist. So we have to understand, because all the differential diagnosis and all will depend on basically the motor unit. So from the proximal muscle weakness, where you may have the reduced or absent reflexes with contractures, with maybe facial weakness, with the static core, is when you're thinking about myopathies. Now, floppy child also we have to see, because many your myopathy may floppy child, but you have a floppy child have again a central component added to it, which complicate matters sometimes because the child with muscle problem has had SIE, which is complicated. Floppy child. Giving you a case vignette of how we come to across a child such a kind of condition. So we have a female neonate which was born out of a consanguineous marriage by an elective section at 37 weeks with birth weight of 0.2 kg. Antenatally, mother had polyhydramnios and reduced movement. And on examination, the child had poor respiratory effort and was floppy. So the possibilities to be considered in the scenario would be an SMA because of the commonness of the thing and the congenital myopathies. Then other differentials would be congenital muscle dystrophies, congenital myotonic dystrophy, myasthenic syndromes. Then you have to also keep in mind non-5q SMA, metabolic myopathies, and Prader-Willi syndrome. They all will come under the differential. We all understand an SMA would be presenting classically, and some of the smaller ones would be maybe having a fasciculation, and the older one may be having polymyositis. And we also have to keep in mind the non-5q SMA. So coming to the main thing is myopathies are basically a heterogeneous group of neuromuscular disorders which are defined by a distinctive abnormality in the skeletal muscle. Most of them have genetic basis. They may present either infancy or early childhood, maybe non-progressive or slow, or maybe progressive. So they generally have a generalized weakness with a hypotonia, a poor muscle bulk, and some elongated faces and open mouth, pectus carinatum, scoliosis, foot deformities, and a high-arched palate may be there. So basically, there can be a considerable overlap between the congenital myopathies and other disorders having hypotonia and a floppy child. So in that can be CMD, SMA, metabolic myopathies. We have to keep in mind Pompe's in this situation because of the treatable component to it, and congenital myasthenic syndromes. But if you have a predominant facial weakness with or without ptosis, generalized hypotonic frog-like posture with hyporeflexia, and you may have weakness and dysfunction of the respiratory and bulbar muscle. Extraocular muscles have to be always looked for because they may be involved in some. Sensation is generally intact and intelligence is usually normal. But you have to keep in mind that if these features are present, then you should consider alternative diagnosis in the form of BRIS reflexes, CNS abnormalities, tongue fasciculations, which is going towards SMA type, and presence of dysmorphism, metabolic abnormalities in the form of lactic acidosis or metabolic acidosis, or extreme joint laxity with collagen 6 and seizures. And I mentioned to you earlier that these children may be prone to having HI, so you may have a coexisting CNS changes. So they may have a mixed picture. And rapid deterioration in the first year is uncommon. Depending on the facies, whether you have ptosis, ocular malalignment, C-shaped upper lip, facial weakness, ophthalmoparesis and all, you have to think about things like congenital myasthenic syndrome, which will be having fluctuations, maybe having mitochondrial, in which you may have ptosis, ophthalmoparesis. There may be generalized weakness and hypotonia with cardiomyopathy, as in Pompe's. You may have Prader-Willi with hypotonia and bulbar dysfunction. So in this patient we were talking about, on examination, the neonate had lack of poor respiratory efforts, generalized hypotonia, absent reflexes, and frog-like posture. No other external malformations were noted. So what investigations were to be done? So ECG was normal, CK was normal, LFT was normal, and SMN gelation was negative by MLPA. Cranial ultrasound and MRI were also normal. Biopsy had not shown any abnormality on the routine H&E part. But the central nucleus was noted in moderate number of fibers. So how do we proceed further? You have to give a muscle biopsy. And it is very important to understand and re-emphasize that H&E may be helpful in some, but we have to do biopsy only in centers where you can do all the other testing, all the other staining, including IHC, enzymes, and in immunohistochemistry. Otherwise, it is not ethical to do a biopsy because you can't have a re-biopsy done of a biopsy. You may like to do a modified Gomery's, you may need oxidative scans, ETPase reactions, and then you have to consider genetic testing. This I've just mentioned that nowadays with some imaging, you may have some clues which will be coming to in the subsequent slides, which may help us find out some structured, focused genetic testing. So basically, if the muscle biopsy has a pronounced type 1 predominance or uniformity, and the type 1 hypertrophy is there, very small fibers are there. And in many congenital myopathies, these features are associated with other pathological features that can be seen on direct molecular analysis. And there may be some overlap, which we will be coming through. This is the classical teaching, which is there, the central nuclear myopathy. And and then you may have mammalian rods, which can be there. This was in the Gomery trichomes, or you may have core on the oxidative staining, or you have congenital fiber type disproportion. What I wanted to see that the many genes which can be responsible for these conditions, that has to be kept in mind. Pathogenic mechanisms have been studied, and they say that what are the various postulated mechanisms. They could be a thin filament dysfunction, they may be protein turnover dysregulation, membrane trafficking and or remodeling defects, oxidative stress issues, altered calcium release from the sarcoplasmic reticulum, disruption of cytoskeleton structure integrity, aberrant myosin activity, or destabilization of thick filaments. These all may have future therapeutic implications. That is why it's important to understand. So this was the various classical images which are there. What is there that histologically you have central nuclear myopathy with the central nucleus which stains dark with oxidative stains with the pale peripheral halo, and you have genetic correlates of MTM and DNM2 and RY, R1, Nemulin rod is another common one, which has intracytoplasmic rods stained red with modified Gomery trichome and has nebulin or acta mutations and many others. Core is something also seen commonly with central core myopathy or multimini core, and the cores are distinct areas devoid of mitochondria with no oxidative staining present, which can be with RYR and SCPN and titin. And congenital fiber type disproportion is also another common one, in which type 1 fibers are less than 35 to 40% type 2 fiber size, and they also have there's a genetic correlates. There's specific biopsy features. You may have some caps. Their cap is there, which are the well-demarcated peripheral eosinophilic areas on H&E stain, and they stain negative on ATPase. They can have specific genetic correlates. You may have intranuclear rods. You may have radial cytoplasmic strands, like you have this spoke wheel pattern, and you may have dystrophic features. You may have intranuclear rods. So all these things are there, and that can help us guide to the etiology for these children. Centronuclear, you have centrally placed nuclei in a significant number of fibers, along with perinuclear clearing of cytoplasm and radiating filament, better seen in immunohistochemistry. This is an Nemulin rod myopathy, which have a normal appearing myofibers in H&E with the green to reddish green material fibers and the modified Gomery trichome. And you may have Z needle-shaped rods, which consist of the Z-band material on electron microscope. This is the central core disease, which has a normally appearing as a myofibers on the H&E stain and having a punched out kind of unstained cores on oxidative stores on the NADHDR, and also can see the electron microscope with this pores. In the mitral ones, you may have you have this you have this bluish fiber normal muscles, and they have numerous COX negative fibers are there. You have a ragged red fibers, and you have this zipper-like inclusions which are there on the electron microscopy. So this one is also showing for the absence of collagen staining. Is there in another case. Electron microscopy, as I mentioned to you, it will be this parking or zipper type, which was talked about in the mitochondria, and this is the white is the fat. This is the which is there in the lipid myopathy. One thing more is that when skin biopsy can replace muscle biopsy. We've done about 3 to 4 studies in which we had tried to see, initially started with DMD, and then we started to see other muscle dystrophies and to understand whether ultimately we can replace the muscle biopsy, skin biopsy, because it has the erectile pylori muscle. It can be used for staining and understanding for diagnosis, and can be used for prognostication and follow-up also, doing follow-up treatment response to newer treatment options. Our parents will not like to repeat the muscle biopsy, but skin biopsy being less invasive could be helpful. Now, coming to age specific some features which can which can give us some handles, clinical handles, like facial weakness in newborn infants, ophthalmoplegia, ptosis, facial dysmorphism in the form of long face, high arch palate, bulbar weakness. They all can be we can suspect as specific conditions, and we can have the differentials to it. Severe respiratory weakness, prominent axial hypotonia, congenital hypotonia. You may have club feet, you may have hip dislocation or arthrogryposis. All these may be in the newborn and infants. When you see, you have to think whether it could be a congenital myopathy. In the older children, you may have scoliosis, rigid spine, cardiomyopathy, foot drop, malignant hyperthermia, which is seen classically in the core diseases, and respiratory involvement and axial involvement out of proportion to the skeletal muscle involvement. But there are certain genes which can be presenting basically with adult onset congenital myopathy as well. So keeping in mind the newborns, the children, and the adult onset. And there are some specific findings on the muscle biopsy, as I have already mentioned earlier, which can guide to which particular genes. So it is not only, we're not talking about only radiogenomics, but here you're having investigations in the form of muscle, the muscle pathology as radiology guiding. Radiology, I will be just mentioning. The MRI, what I was mentioning to you was MRI will give you some guidance. For the Nemulin one, you may have in the mild ones, you may have relative sparing of thigh. And in the severe ones, you may have the severe involvement of lumens. Then you may have some specific involvements can be there. I need not go in details right now, but it can be seen that you can, with the aid of specific MRI features, that you can have suspect some particular conditions. The main MRI approaches. whether there's a predominantly proximal involvement. Yes, then you see whether the tibialis anterior is involved or not, and after tibialis anterior, whether soleus is involved or not. If soleus is involved, then you have acta, nebulin, or TPM. But if it's, there is no involvement, then you and soleus is left effective, and then you have to think about the whether it's SEPN, and if it's soleus is involved, then R/R1. If you have a posterior component involved, then the soleus involvement has to see. So you see of DNM2. So basically, if you just have to understand, then you have clinical cues, clinical handles. Then you also have pathological on muscle biopsy, which is going to be using from the H&E to specific enzyme immunohistochemistry and immunohistochemistry and the EM, and also the muscle imaging. They all can guide to which kind of congenital myopathy we are dealing with. So that is how it is important to understand. And you have all the various spectrums and various muscle which can be involved in the congenital myopathies. So another thing is, besides the MRI, ultrasound can also help. Ultrasound of the normal muscle has now been graded into, ultrasound has been graded into 4 grades by the HECMED score, in which grade 1 is normal. And you have basically characterized, and it's easy for any radiologist to learn and do it. You can make out between a normal muscle, a congenital myopathy, in which the fascicular architecture, the fascicular architecture of the normal muscle is absent. You have a smooth, homogeneous hyperintensity in the appearance, in the hyperechoic appearance. You may have the CMD, in which you may have partially preservation of the fascicular architecture, and you may have in SMA the fascicular architecture is there. There may be streaky hyperintensities. And this was a child who with Nemelin myopathy, whose ultrasound was there. So an ultrasound which is non-invasive and do not need any sedation can be easily done and can give us clinical cues. We have done 2 studies on that, and it should be more developed further, ultrasound. Then, as I mentioned to you, that various conditions, various muscle pathologies can have are caused by various genes. So like Nemelin myopathy has various genetic correlates. Similarly, for core centronuclear myotubular, all of these, you may have multiple genetic determinants can be there. So basically, when you suspect a proximal muscle disease and you have hypotonia, weakness, and delayed milestones, you do a physical examination. If you're going to see, and when you see for ptosis, you see for respiratory dysfunction, extraocular muscles, cardiomyopathy, contractures, myopathic facies, nexoaxial weakness, hip dysplasia or scoliosis, or severe hypotonia. You see that, and you can get some clues to various myopathies. And when you get a CK done, when CK is normal or mildly elevated, then you may do a MRI and or genetic testing and or muscle biopsy. And then, because on muscle biopsy also, whether having rods, cores, central core rods and caps, or congenital fiber type disproportion, you have various genetic correlates. So based on your history and examination and your CK being normal, and then with the combination of a muscle MRI, genetic testing, and a muscle biopsy, you can basically by a muscle MRI and the muscle biopsy, then you can decide on the genetic testing, and you may do a final diagnosis is a combination of these 3 factors and understand what it is. Basically, anybody with hypotonia, hyporeflexia, with or without ptosis, ophthalmoparesis, facial weakness, paralytic weakness, static or slowly progressive, CPK may be normal to 2 to 3 times normal, and then you can do a muscle MRI, and it can guide you a genetic testing. So it is, and you have to individualize a decision whether you want to do both a muscle biopsy or a genetic testing. Sometimes these days now parents are going only for a genetic testing. But you keep being in mind that that your differentials are congenital muscle dystrophies, in which you may have a CPK which may be raised. In congenital myasthenic syndrome, you may have ptosis, you may have fluctuation, you may have RNST which may help, or you may have a double CMAP. In SMA, you can have fasciculations or tongue fasciculations, or you may have polymini myoclonus. In Pompe's, you may have fasciculation, but you may have cardiac involvement. So all these things, and myotonic dystrophy, you may generally have, you may have a mother who is having myotonia, and there is generally an anticipation in this. So this was a double CMAP of a slow channel myotonia. We had seen earlier 3 cases. This was long back in 2012 when the genetics was not there. This was basically based on the muscle biopsies. We had 9 Nemelin rods, 9 central cores, 9 mini core. CFTD was 7, and Desmond related 2, central nuclear 3, and 4 could not be specified. This was the time of pre-genetic era. This was a child, a 2-year-old girl, with have a poor gain of milestone with some sleep delay, with ptosis and mild bulbar weakness and a paralytic hypotonia. This child ultimately ended up having a mammalian rod myopathy, and the genetic testing was showing the same. It was showing the problem in the mutation in the NAB gene. This is another patient, a girl who is an 8-year-old girl who had a delay in attainment of motor milestones and difficulty in running and climbing stairs and difficulty in getting up from squatting position, or predominantly motor delayed. And it was not progressive, it was non-progressive. And on examination, there was a long facies, a ptosis, a Gauber sign was there, and bulk was symmetrically decreased, and hypotonia, appendicular more than axial, hyporeflexia was there, and the clinical possibilities thought out were congenital myopathy or SMA, and the muscle biopsy was inconclusive. And SMN gene deletion was absent on MLPA, and CPK was normal. It turned out to be a central core disease with RY1 mutation. Another one, 4-year-old girl born out of a 3rd-degree consanguineous marriage, had delayed motor milestones, which are predominantly proximal, could walk independently only by 3.5 years of age, and it was non-progressive. And she had a Gauber sign and a long facies and a hyperextensible joints, and laxity was there, hypotonia and hyporeflexia. And we thought of congenital myopathy versus SMA or congenital muscle dystrophy. And SMN gene deletion was absent. Muscle biopsy gave us a picture of unclassifiable congenital myopathy, and EMG was myopathic and is normal. And then we found the child was having Col 6A3 Bethlehem myopathy. There was another child, a 10-year-old child born out of a non-consanguineous marriage with short stature and worsening breathing difficulty for 6 to 7 months. In view of respiratory failure, the child was intubated, and the child had difficulty in climbing stairs and was taking more time to eat historically. And after 2 days, the child was extubated, but he had to be re-intubated. And after 1.5 months of a hospital stay, the child had expired. The child was thin built, and muscle book was significantly reduced, and CPK was normal. Nerve biopsy was predominantly demyelinating neuropathy. NCS was motor and sensory neuropathy, and muscle biopsy showed neuropathic changes. Pompe and SMN were negative. Echo showed asymmetric septal hypertrophy, and the clinical exome showed BAC3 mutation, BCL2 associated athanogene 3. And this was the time in 2015 to May 2019 when we had the genetics testing available. We had 35 cases of congenital myopathy, out of which the most common, the myopathies which were there, we had a core myopathy was 17, and 2 were mammalian rod, and others were in a quite a mixed bag kind of thing. And before that, we had out of 750 muscle biopsies, we had 15 myopathies which were mammalian rod, and 985 biopsies we had, only myopathies. So out of 25 cases which we had reported earlier also, and we basically that time we had the central core was most commonest, followed by mammalian and multi-minor. Pompe's also we had taken out a series of which were there. So basically, we have gone to central nuclear and just want to understand that you have 6 genetic mutations which can be there predominantly. Eye involvement is there, can have neonatal onset. You may have in the central nuclear or tubular, you may have onset which is an ophthalmoplasm, and this is the and if you have fiber type proportion one in which you may have genes involved, but a few of the genes involved, it can take or slowly progressive course, and you have related hypertrophy of 5.1 fibers compared to 5.2. And basically, in mammalian, basically it is the Montgomery's aggregates mammalian is thread, they are rod-shaped, inclusion like abnormal structures, and you may have cat showed you, or you may have zebra body. That's how this is mentioned. They may have presence of significant vulvar dysfunction, and they may have variable presentation from severe congenital onset. And you have genetic causes there. Then myopathy are best seen on oxidative stains, and you have core and multi core, which can present from mild to severe with motor developmental weakness and hypotonia. And you have by RYR, and you have mild facial movement and ptosis can be. And you may not much in detail. I will just want just 2 minutes to 3 the advances in management. The management basically holistic evaluation of the child having muscular muscular problems outside the motor unit, and to see besides the skeletal problems, and which will decide, which will aid us to diagnose, also to the child specifically, and to prognosticate treatment and genetic counseling. The what I wanted to remember about our malignant hypothermia to RY1 patients is important to be kept in mind, and has to be, as we told these patients, discussed, as well as the the malignant hypothermia to RY as early and the disproportionate degree of risk involvement in SCPN mutation, they need to be kept in mind. Multidisciplinary the management, important growth and development, and the feeding problems has to be taken, and nutrition has to be taken account, and the scoliosis. These 2 things get missed. Vitamin D, calcium supplementation, very important to be seen, and see the potential cardiac, respiratory, orthopedic issues, and talk about the perioperative management and anesthesia, and maybe you need the ECG, PFT. Respiratory complications beyond infancy may be found, but certain kind of conditions only. The newer whatever the recent advances has been there is the CRISPR-Cas9 gene editing, AV9 for myotubulin through the canine thing, and it is also being targeted for central nuclear being done in mouse models, and myostatin inhibitory treatment. The near thing is gene replacement, AV8 myotubular myopathy, splicing modification for DIN, and central nuclear is there. And regarding my AAV8 mediated gene therapy in dogs, which has been shown to have some beneficials, it's been well tolerated, and it's been a peripheral infusion. But in Aspiro, which was a trial for X-linked myotubular in which started in 2017, but what happened was the first the patient was given in 2017 September, but there was a liver-related serious adverse event. Also, there is a DYN. 101 in patients more than 16 years for central nuclear myopathy has also been started. So basically, you have the human is the Aspiro trial, which was there, and the other one is the RYR1 related congenital myopathy. You have an antioxidant therapy associated with this ongoing trial is going on. So you have L-tyrosine for Nemolin myopathy for the ACTA mutation, Dantrolene for RYR1, Salbutamol RYR1, Pyridostigmine DNM2, MTM1, and N-acetylcysteine for central nuclear has been studied. There's now a recent role of microRNA, which has been shown that it can be, involved in the pathogenesis. So it is important to see that, it is coming as a therapeutic target besides being a biomarker. And it has been shown also for Nemolin myopathy. And the another thing which has come up is autophagy, which is being studied in various central nuclear myopathies, and a link between MTM1 and autophagy is there. This also will be having, therapeutic implications which are there in the new things. The new genes are being found out, and another paper which was there, although it's 2017 paper, but one thing was there for diagnosis. One has to remember RNA sequencing was done in a cohort of 50 patients with undiagnosed rare muscle disorders who did not have a diagnosis, following massively parallel with sequencing with genomic things, and you had a diagnosis in 35% of them. So we have to just keep that in mind. So, but what practically speaking, we see a hypotonic child with, and then we will like to see whether it is, early onset involvement in the, infant, or a child in the childhood with a motor delay, with hypotonia. And we always like to do an SMA because of the commonness. After the SMA, if it is SMA gene deletion is negative, then only we go ahead. And if we are strongly suspecting SMA, then we do an SMA targeting sequencing. But if we are not suspecting SMA, that it could be anything else, then we go for an exome sequencing in these children. That is how we are trying to do. And they said the muscle MR biopsy as well as MRI and ultrasound may help us, whether we can do them targeting sequencing. They generally non-progressive, very slowly progressive, usually not associated with multisystem like cardiomyopathy, and rarely associated with dysmorphic features. Muscle imaging can be helpful and guide us. So we should suspect if a floppy baby with facial, bulbar, extraocular involvement, always examine mother for myotonia and myasthenia. In the presence of brisk reflexes and fasciculations, dysmorphism, metabolic abnormalities, consider alternate diagnosis. You need to do a phenotype down and a genetic up approach. Muscle biopsy and muscle imaging will help. We, as a part of a central excellence, are trying to do and study advanced diagnostics for all muscle dystrophies, not exactly myopathies we are doing for non-DMD muscle dystrophies, but next step would be we'll be going it for the myopathies as well. We also have an app to diagnose neuromuscular disorders as a part of neuromotor impairment. But my final message is, for any of these children, we have to think about musculoskeletal growth, nutrition, pulmonary, cardiac, systemic evaluation, psychological counseling, besides giving them OTPT and respiratory support. This is all important, and you have to give parent information material for these patients. And hope has to be given, but always remember that when there are two things. One is that we have to do, these children has to be given transitional care to transition to adult neurologist. And second thing is decide when it has to be palliative care, with humanistic aspect, looking at it, giving palliative care to somebody who's terminally ill. And very grateful to all the parents and children who have been given us opportunity to treat them. And thank you again, and API, especially Nirmal Sir, to have given this opportunity.
Thank you, Dr. Shefali, for elaborative approach for the congenital myopathy, along with involvement of the multiple therapists with the sign of hope and with saying about the SOP for the floppy infant. Thank you. There's a few questions are there. It's in the chat box. In myasthenia gravis, what should be the starting dose of steroid? Should we have to start with high dose or we have to build up? Dr. Thomas Matthew.
Yeah, it is always safe to build up because there is a potential chance of worsening by second to third week. So we can go at a lower dose and go up. So start maybe with 5 milligram or 10 milligram and then slowly go up if you are planning to give steroids.
Okay. Next, what should be treatment policy of drug-induced like penicillamine, myasthenia, where persistence of the symptoms, anti-acetylcholine receptor antibodies are there? Dr. Matthew.
Tough question. When there is a drug causing a disease, we stop the drug usually, unless you are. I don't think we have only one option. I don't think whether the question is on a Wilson's disease patient on penicillamine and is getting myasthenia. That is a tough thing to manage. Otherwise, usually if any neuromuscular disease is caused by a drug, for example, certain drugs are very notorious to worsen neuromuscular junction disorders. We have aminoglycosides, we have levofloxacinolones, group of antibiotics, erythromycin. So they can all worsen. So when you suspect a drug which is worsening a myasthenia, we just stop the drug or avoid giving that. But you are in a stage where you have to give that drug and then you have an antibody mediated disease. I think then in a rare case, we have to do immune suppression. We may have to do something. One of the drugs we'll have to choose and treat. You have no other option.
Next is again for you. If AChR or MuSK is positive, more than 80% with supportive clinical feature, is RNS required?
Yeah, that is a better to have all things together because these antibodies can at times be false positive. Not MuSK I have not seen, but acetylcholine receptor antibodies can be false positive. So we have to have clinical correlates. We should have electrophysiological evidence and the antibody all together. Don't go by one thing and you can have mistakes because even demonstrating a small fatigable ptosis is very common. So we have to be very careful in diagnosing these conditions because you have on long-term immune modulation and things like that. So pretty sure to have all the evidences before you start treatment.
So you are in great demand. Next question is again for you.
I think treatable diseases people are attacking.
What to do if a myasthenia gravis patient who already underwent thymectomy now again comes with increasing weakness?
Yeah, then we have to do many things. As in any other case of myasthenia, we have to see whether there is a recurrence of thymoma. We CT and see that something is recurred in the thymus. If nothing is there, the myasthenia is appearing again. And that I told, it's not a direct relationship between the thymus, and we have seen many patients, after the thymectomy, again, they have worsening of myasthenia. So it can be the concept I was telling, there can be long-lived plasma cells, which can remain in other sites, not in thymus, it may be bone marrow or the secondary lymphoid organs. And then the long-lived plasma cells live a lifetime, can stay for a lifetime. So they are years. Short-lived plasma cells last 3 to 5 days. The long-lived can go for years. So this may come up again because you have not attacked the plasma cells which are secreting the antibodies. So then you have to treat. Again, you start treatment. But also we have to, just now, yesterday, a few days back, a patient of 10 years of ocular myasthenia comes with a mild weakness proximally. So the conventional teaching is you have a pure ocular myasthenia for 2 years, your chance of generalization is less. So then we are looking at, so she was on a beta blocker. So calcium channel blockers, beta blockers can worsen neuromuscular junction. So just I've taken out that beta blocker, she was on metoprolol, and surprisingly the weakness improved the next day. So it just improved. Within few days, she felt better. But she was antibody positive and RNS showed decremental response in the trapezius. So I've given rituximab to her directly. So now my strategy, it's my personal thing. I feel rather than mixing up so many things, steroids, azathioprine and stuff, early in myasthenia, you give rituximab straight. It will be a very focused treatment and patients may do well without much other problems. When you combine more and more things, steroids with rituximab, then your chance of infection goes. And things like musk myasthenia, both the pyridostigmine and steroids may worsen. So better to have just straight strategies so that we are very clear on things. And that was the Swedish trial. This was our intuition from 2014 to 15. We were trying to publish our short case series by the time the Swedish people came with a larger study showing their, and if you see that their latest treatment, if you see that table which I showed, from 2012, I think they are using more rituximab. You don't have much of the conventional immunosuppressive treatment in their slide.
Thank you, Dr. Khadilkar, sir.
Yeah, I just wanted to make a comment about the thymectomy. I think it's important for people to realize that thymectomy in myasthenia gravis is not curative. It is supportive. So it's one other measure that you use in people who are not doing too well. So the first presumption that a patient should not worsen after thymectomy is in a way not based correctly.
Absolutely.
I think the myasthenia will behave the way it will behave. Thymectomy will generally turn them onto the right path, so to say. Yeah. So then it's treated as you would treat those where thymectomy is not been in question. Yeah.
I think Dr. Meshram is also in the panel. Okay, sir. I think all the questions is being covered up. So over to Dr. Nirmal Surya, sir.
Thank you all. This was a wonderful session, and I think we had a good attendance everywhere, including on the YouTube as well as on the Facebook. There were a couple of questions were on Facebook, which I forwarded it for Dr. Matthews. I think myasthenia is the topic which has not been discussed much in the physicians meeting, and that's the reason I think it has excited them. And Thomas has given some new ideas of rituximab, so everybody is really excited. So we come to end of the Series 6. We will be looking forward to Series 7. And I was just wondering, I thought that we started on 26 January, so we may continue it on 15th of August. So 15th of August is Monday, and we can have the meeting in the evening, 5 to 7 p.m. on neuropathy. So our next session will be on 15th of August. In neuropathy, the detailed program, we will forward it to you in due course of time. And once again, thanks to Dr. Maheshwari and all the speakers, particularly Dr. Khadilkar, Thomas, Shefali, and Seema. Rajendra, you have been there. So thank you very much. Thank you, everybody.
Thank you, Nirmal sir, for inviting. Thank you. Thank you, sir. Thank you, Maheshwari sir, for coordinating.
Thank you, sir. Thank you for the opportunity.